Hello, guys. I would like to be the first one to welcome you to your very last first. This is your first lecture of your very last class. Yay, we're almost there. And pretty soon you'll be taking that NCLEX, passing it, and I get to see you in a hospital or hear about all of your wonderful adventures as a nurse. I know a lot of you have already pledged jobs. I mean, that's amazing. If you haven't, don't worry about it. We are going to get into this first topic. Let's go back to emergency nursing. We're going to do overview, triage, trauma. I'm going to break this up into two lectures because, frankly, I just don't have enough attention span around for all of the content of these. So our learning objectives for you guys, we're going to go over the overview of emergency nursing, history, triage, nursing roles, and responsibilities. And in your second lecture, we're going to do some understanding of some basic trauma epidemiology and go over the overview of primary and secondary surveys during a trauma event. And this is normally, that last one is normally a 2-day class, so we're just gonna hit like all the high points of that one. It's just a lot to dig into. Just letting you know that you're getting the condensed version of that one. Little hyperlink that you can link into on your own time, but it basically kind of does a little day in the life of a ER physician. Back a couple of years ago, they didn't have all these videos, but everybody wants to know like the day in the life of now we're all wanting to see each other's protein drinks or something like that. I don't know. YouTube takes me down some rabbit holes when I go through these researching these for you guys, but just basically I want you to take a look at the teamwork among the ER staff and through like EMS, calling cardiology, all of this stuff that encompasses a team. It's really kind of interesting. If you guys have time, there's a couple-hour movie. It's a documentary called Code Black, and it's set at USC in Los Angeles, and they are just very famous for having like the busiest ER in the country, and it might scare you a little bit, but you will understand a little bit, kind of more in depth about the process of emergency medicine there. I highly recommend that movie. Little brief history on emergency medicine, and we can kind of credit this French revolutionary surgeon named Dominique Jean Larrey, and for its inception, he in fact created the word triage, which means to sort, and so they were able to give higher priority to the falling soldiers that were in the battlefield there. And he actually, had this little horse-drawn ambulance, which is kind of interesting to see. It would be such a bumpy ride, but there's your kind of inception of emergency medicine. Back in 1961, they created this 24-hour-a-day, 7-day-a-week physician-staffed emergency clinic. So something that was on the more reliable side as far as care is concerned. But this was staffed by residents. It was staffed by physicians, like primary care providers, things like that. They were just using everybody to keep this one open. And over these next 10 years, they decided that there was some really good evidence that said if you can specialize in emergency medicine, then the patients had better outcomes. So then rolls in the very first emergency Department of Emergency Medicine. So we're now able to specialize here. And that started in 1971 at USC, University of Southern California. So pretty new-ish specialty. War has impacted a lot of things as far as emergency medicine goes, and emergency medicine has impacted a lot of things that are implemented in the wars. So I just thought I'd kind of share with you a little history of how nurses impacted the wars. So back in World War I, World War II, emergency nurses brought in infection control, and there were nurses on the front lines. They were able to triage these patients and care for them based on priority. And in the Korean War, there was the capability of more rapid transport, i.e. helicopters, of the wounded to the hospitals. And they started using air medical transport. So over time, they were actually able to, kind of help these patients in that golden hour of need instead of just transporting them. In the Vietnam War, there was a system of trauma care from field to tertiary hospitals. So these kind of progressed in the way that they were able to care for the patient during transport there. And now in our current wars, we have the capability of rapid transport and care during transport, as well as the capability of any specialty we want via telemedicine to provide their input. More recent history of emergency nursing. Back in the 1980s, there was some development to make some systems more universal. So no matter what emergency department you go into, you are going to have some universal care there. So they developed the Certified Emergency Nurse, the CEN, and the Trauma Nurse Core Course, the TNCC, which is that 2-day class I'm breaking down into just less than an hour. And it wasn't until 2011 that the American Nurses Association recognized emergency nursing as a nursing specialty. So pretty new in its kind of history there. There are some education and certification requirements that emergency nurses need that maybe other specialties do not need. One is basic life support. Basically, everybody needs that one, right? But in addition to that, since we are working with pediatric population, we will need pediatric advanced life support and the advanced cardiac life support, which some of you guys have already had the opportunity of doing. In addition to that, they would like you to have the education for trauma, which includes that Trauma Nurse Core Course or the TNCC and Emergency Nursing Pediatric Course. So those get a little bit more into the traumas. And if you have a hospital with a neonatal intensive care unit and NICU, you will need a neonatal resuscitation program, or if you're a flight nurse, you need that. And then extra requirements or certifications that you could have are certified emergency nurse or certified pediatric emergency nurse. I happen to be a certified emergency nurse. It just entails paying the money and going to take the extra certification test, but it provides you with a great amount of literature on emergency medicine and a sense of community there.
You are what you love, not what loves you. That's what I decided a long time ago.
Page insert for Karina. What I find so cool about emergency nursing, there's a few things. One is the autonomy there are a lot of nurse-initiated orders, which allow emergency nurses to think critically. So, for instance, we have a patient that comes in with chest pain. We get to order an EKG, chest x-ray, aspirin, maybe their nitroglycerin, and the appropriate lab work before the physician has even gone into that patient's chart sometimes. So we're able to think kind of critically and on our toes with those, and the teamwork, I can't stress that one enough. That's really, 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 really important in the emergency department. We really depend on our team, and the team depends on you. So I found this great little Phil Jackson quote. Phil Jackson is the coach of the Chicago Bulls, or was the coach of Chicago Bulls and the LA Lakers. He's just, semi-famous there. He says the strength of the team is each individual member, and the strength of each member is the team, which I thought was impactful. A couple of other things I like about the emergency department: it's nice and fast paced. There's a lot of activity and alarms going off. There's no close signs, so we just never know the kind of rush we're going to get, and it really is exciting to be able to kind of master those things and challenge ourselves with that. And lots of variety, unplanned situations, unpredictable census, and you get to work with every kind of patient, from the ones that haven't even been born yet to the very, very old, as well as different disease states, and then various injuries there. You get to play a little bit of a detective because patients come in not diagnosed, and we get to do all the work for that. So major goals of the emergency department, there's three of them, three big goals. One is to preserve life and limb. The second one is to stabilize patient for definitive care. And the third is to restore the patient to functional living. Classic example of that third one would be a stroke patient that we might be able to give like TPA to or something. Lots of players involved in the emergency department. First is the nurses. We've got our triage, our check-in nurse. This is supposed to be a very experienced nurse because they're able to tell the sick from the not sick and get the patients into their appropriate situations there. The next is the charge nurse, who directs the flow of the department there. Then we have our stretcher side nurses, or bedside nurses. Average patient to nurse ratio for these guys is 4:1, so 4 patients to 1 nurse. If we have less acute patients, then you might see a 6:1, and then if we have a very, very acute patient, like an ICU patient, critical care, trauma patient, then we'll have a 1:1 or 2 patients to 1 nurse. And we have our nurse managers, coordinators. We have a trauma and a stroke and clinical coordinators. Trauma and stroke, lots of evidence-based practice that creeps up all the time, and so we're constantly changing how we're doing things, and we need a nurse coordinator to help us do that. Then we have our clinical educator there. Obviously, we have our physicians and our mid-level providers, our ED techs or CNAs. Our techs can do a little bit more than the CNA can do on the floor. They get some splint training there. They teach people how to do crutches. They fit people for boots and like I said, splints. They can also generally do some phlebotomy work, and they work really closely with the quarantine team. If there was a case where, plant in the area had a big, huge chemical exposure. They do some decontamination training as well. Then we have our secretaries and unit clerks, and then, of course, the patients. That's what we're here for. Lots of support players that we'll see down in the emergency department. We got a respiratory therapist, a radiologist, laboratory, our members of the cath lab. We have admitting physicians, hospitalists or intensivist, and then consulting physicians, which is every specialty under the sun. Then we have our social workers, case managers. Those are oftentimes also nurses, but discharge really begins upon admission, and these guys work really, really hard to get the patients the resources they need for a safe discharge, which is really, really outstanding. Then we have our support units like our ICU and acute care. Sometimes those specialties will help us when we call codes overhead, such as if we were going to have a blood transfusion, a mass transfusion for a patient, the fourth floor, one of the fourth floor nurses comes down and helps us out with that. And then we have our emergency responders, flight crew, paramedics, emergency medical teams. And then last but not least, our patients. They come from all over the place, like long-term care facilities, assisted living facilities. They might walk in from home, prison. The police might bring people in, ambulances, urgent cares, clinics, all over the place. So lots of variety with our patients. It's just really the general population. Emergency nursing and emergency medicine, it has some laws that are directly affecting the way that we do things down there. So we have like our federal laws, our state laws, and our mandatory reporting laws. A couple of the federal laws you guys should be privy to by now, such as the Emergency Medical Treatment and Active Labor Act. You might not be as privy to that one as definitely the HIPAA laws, right? So you guys are very well aware of what we need to do to keep our patients' information safe. Then we have the Affordable Care Act or Obamacare. Things are kind of transitioning if you guys are reading the news, so maybe this slide won't prove time-worthy here pretty soon, but that's kind of what we're structured at right now. These things just get changed in legislation all the time. Then we have our state laws. I encourage you guys to take a look at the Washington State EMS and Trauma Care Act that I have linked in for you all. And then we have our Nurse Practice Act. This is through Washington State or whatever state that you are going to ultimately practice in. You should be knowing the laws, right? The Nurse Practice Act, will define and limit scopes of practice and protect the public. More on that here in a couple slides. And then we have our mandatory reporting laws, which I'll speak to here in a moment as well. So EMTALA is kind of interesting, somewhat unique to the emergency department. It was structured by Congress in 1986, and prior to its inception, some hospitals were like dumping patients because they didn't think that they were going to be able to pay, and kind of like crooked things like that. So basically what it means is that if you have opened your doors as an emergency department, you have to provide a couple of things. You have to provide a medical screening exam by a provider to determine the presence of an emergency medical condition. It's like the very least thing that we could do. And then within the department, as the patient, progresses into sick, the law says we have to provide appropriate stabilizing treatment. So we can't just dump a patient off into another facility without stabilizing that patient. And we must obtain written consent for transfer. These are all important things. We must verify receiving facility and physician have accepted the patient. sometimes this is kind of a lengthy process, especially with the hospitals being like as full as they are right now. It takes some work on the care team's end, and we must verify that the receiving facility actually has a bed for the patient. So that's a coordination with like our transfer center and things like that. So HIPAA, once again, provided a little link for you guys that talks about the rules that are mandated. This was initiated in 1996, and like I said, we're all pretty aware of HIPAA by now, but it really protects that patient against electronic health information. If you don't know or don't need to be in the chart, don't be in the chart. We all know things like that, right? And then Obamacare, which was initiated in 2014, was kind of designed to help ease the way of emergency departments by getting to that patient prior to needing the emergency department, not utilizing that as like their first line of resources there. But unfortunately, there hasn't been a lot of participation between providers. It's actually can cost them a lot of money. So there's some things that are slightly broken with that, although time will tell whether those will be easily fixed there. But in reality, kind of increase the emergency department visits nationwide. So we just really need to keep an eye on affordable health care or for those patient populations that are in need. Washington state laws, I've once again allotted a link to the Washington State Department of Health license and permits and certificates. There's some laws in there that are interesting. So our Washington State laws will define training standards, define scopes of practice, and allows for licensure and disciplinary authority if need be. There are some things in the emergency department and elsewhere that need to be mandatorily reported to the state. So these includes death in the emergency department and within 48 hours of admission, death of a child, elder, or disabled adult abuse, elopement of psychiatric patients, so if a psychiatric patient leaves on you, gunshot and stab wounds, infectious diseases, sexually transmitted infections, rape and sexual assault of a minor or a vulnerable adult, and a suicide or an attempt to suicide. Those all get reported on. So I just pulled up the Washington State RCW for mandatory reporting. As a registered nurse, you guys will be required to be a mandatory reporter. So if you suspect any kind of child or adult, vulnerable adult or elder abuse, then it is your duty to report that to the proper authorities there. And I did hyperlink the RCW for that one and highlighted registered or licensed nurse. The good news is if you're wrong, if your hunch is wrong, then you aren't reprimanded for that. You just have to be a reporter in good faith. And sometimes all we have to go on is our hunches, but you'll find out soon that you can rely pretty heavily on those.
Do or do not. There is no try.
Here's the most recent phone number for Child Protective Services. All Alright, so let's get into triage. We're going to switch gears here a minute. So that check-in or triage nurse is going to be primarily responsible for sorting the patients and getting those that are in need of one of those three goals, the proper resources as soon as they can. It's not a first come, first serve thing in the emergency department. If you are worst, then you are first. Unfortunately. So like I had said earlier, triage means to sort, and it's a French word. First person seen is that check-in nurse. They'll perform a brief evaluation of the patient to determine a level of acuity or priority of care there. Added in that the check-in nurse acts kind of as a bouncer to the emergency department. We have 15 patients out there in one bed. That actually happened to me last night. Then I get to decide who is in there, and it's based on how sick they are, not when they came in. These decisions are made within 30 seconds to 3 minutes. Sometimes they're made within like 5 seconds. Like, we need to get this patient back immediately. And in the emergency department, in that waiting room, I ask you if acuity can change over time, and yes, it can. And our rule of thumb is that the acuity only gets worse. So we place a patient on an acuity level, and then we can make their acuity worse as things worsen, vital signs change. Our A's, B's, C's, and D's change too. So acuity, I've said it a couple times, that's the measurement of the intensity of nursing care required by a patient. How much resources going to go into that. Emergency departments use different systems to determine the level of acuity and getting the patient back. At the very least, they can use a 2-level system. So we decide, is the patient sick or not sick? And we'll place them back into a bay, depending on that. Then some emergency departments use a 3-level system. So a red, yellow, or green patient, like, are they emergent, urgent, or not urgent at all? They oftentimes will use a 4-level system as well. So is this patient life-threatening, emergent, urgent, or non-urgent? But the thing that you'll see most is going to be our 5-level system, which I will get into here in a second. What is emergent, what's urgent, and what's non-urgent? So let's take a look here. Our emergent patient is going to require immediate care. Without care, there is risk of loss of life or limb. And these include like our major traumas, our cardiac arrest, our respiratory arrest. You could add in like anaphylactic shock in here, things like that. Our urgent patients are going to require prompt care, but this can be delayed a little bit. So examples of those are like our abdominal pains, our fractured hips, our kidney stones, things like that. And then our non-urgent patients, they will need to be seen, but the time is not critical. Examples of these are like sore throats, rashes, conjunctivitis. So the 5-level triage that I was just speaking about, there is a movement to make this the universal system, and more often than not, if the emergency department is going to be using this system. Shouldn't be confused with the Canadian 5-level system, which is based on the amount of time that's predicted for a patient to be in there. But we're talking about the U.S. So this is, our 5-level system is called the ESI. So you might hear ESI a lot. And that simply just means Emergency Severity Index. So we will take our most acute patients Those are our level 1s, and our least acute patients or lowest acuity patients are going to be a level 5. How do I determine what's a level 1, 2, 3, 4, or 5? Well, this little table breaks things down, and it's like as simple as this and as complex as this, because we're just kind of guessing as to what we think that the patient's going to need as far as resources. And by golly, it's going to be a good guess because you're going to have your strongest team out there doing the triage or care there. So our level 1 patients, like I said, they're the most acute. They're going to be those ones that require immediate life-saving intervention. So get them on in there. There's no questions about those ones. And if you can't find a bed, then you're going to go on to a stretcher out in the hallway or something like that, because these patients need to be seen. Our level 2 is our higher risk situation. Examples of that might be like our rape victims are high risk. They're at risk of losing evidence if it's not collected in a timely manner, things like that. Our confused, lethargic, disoriented patients, those all get bumped up into a level 2. If they have severe pain or severe distress, then those also get bumped up into a level 2. Now, level 3 is a little bit more harder to define, and this is the patient that's going to be needing many resources. I'll talk about resources on the next slide, but at least 2 or more than 2 resources. However, if their vital signs do fall within these danger zone vital signs, then they need to have a consideration for being bumped up to a level 2. Level 4s are the ones that are probably going to be needing 1 resource, and our level 5s, which we don't get too frequently in the emergency department, are the ones that are going to be needing 0 resources, nursing resources. So they'll still get the medical exam, but they won't be needing any nursing resources. So what's a resource? Well, if the patient gets lab, that's considered 1 resource. If they get an EKG or X-ray, that's also considered a resource. Diagnostic studies such as a CT or ultrasound, resources. IV fluids involve resources. Any specialty consultation or simple procedures, that is 1 resource, like suturing a patient, but a more complex procedure such as suturing that's going to require sedation, that's going to be 2. However, the history and physical, pelvic exam, a saline lock of the patient, PO meds, tetanus immunization, prescription refills, a phone call to the patient's PCP, simple wound care, crutch, splints, and slings, those are not resources. So I've added some information down below for more on that topic.
Help you, I can. Yes.
So the triage process, this is going to be starting with an across the room assessment or the look test. Oh, is that patient sick or are they not sick? We're going to go into the triage interview, which involves the patient's chief complaint. What are they here for? In as few words as possible. Back pain, things like that. Ankle injury. History of present illness. So we use the old cards method on these patients. You have ankle pain? What happened? How long ago did it happen? What have you done in the meantime to make it worse? What has made it, or to make it better, excuse me, what's made it worse? How can you describe this pain? And then we take a set of vital signs on this patient. Then we'll do a focused physical assessment. You have an injured ankle. Let's take a look at your ankle. It's a totally different story if we can't feel pulses on this patient and we think that they have compartment syndrome as opposed to somebody that has a sprained ankle, right? So we do that quick look at the patient. It's always a good idea to look at the patient. Then we'll give them a triage severity rating, or a ESI, emergency severity index there rating, and this can be made out. Triage decision can be made at any one of these steps, and the whole process takes like less than 3 minutes. So if the patient comes in, let's say with testicular pain, I've already looked across the room and they look like they're in quite a bit of pain, and they tell you that they have a quick onset of testicular pain. That's actually a level 2 because this patient is at risk of life or limb, and limb is one of their testicles because they have a risk of testicular torsion. So it's kind of interesting how we could do that so quick. We can get the patient back on the scene, get their ultrasound, get their pain medication, and get their consults. So special considerations of this triage, like I said at the bottom, if they're a forensic patient, like we need evidence collection on them, like in the instance of a rape, police custody, or like in need of evidence collection, then we try to triage that patient back sooner rather than later. If they're neutropenic and I have a waiting room full of COVID patients, then that neutropenic patient is going to need some tender loving care and be considered for a room above other people in their same triage category there. In patients that are left without being seen, we need to get them AMA forms. If they could sign it, most of the time it's not going to happen. And then safety of both the patients and the staff. So our prisoners are never in the waiting room. They're always taken or coming from the back. If there's a potential patient, with some gang violence associated with that, we'll get them back as soon as possible, and then lock down the hospital. Code Violet. All right, that was enough of triage. Now we're going to go into disaster triage, which looks substantially different than regular triage. So when we see patients day to day in our emergency department, triage looks like we're going to use all these resources on our sickest patients, right? If they're in respiratory arrest or cardiac arrest, we fly to them first because we want to take care of these sickest patients first. But disaster triage looks a whole lot differently because now all of a sudden we have a multitude of patients that need cared for. So how do we do that? Well, we take care of the most people and try to do the greatest good for the most people. And this is an ethical principle called utilitarianism. And this is like all things being equal, and all things are equal in this concept of ethical practice. And it really means just doing the greatest good for the greatest number of people. So we're not going to pour all of our resources into the sickest patients. We're going to help those that are that are urgent first, because we need to consider the whole system. And this is defined within different regions based on hospital resources. So each community makes up their own disaster care plan, and ours involve all of the hospitals that are in the area. So this is an example of how we can triage a person during a disaster. Let's just say that there is a 15-car pileup, and we have gotten a report from The 911 operator, just a heads up, there's a 15-car pileup. We have no idea what's going on. Okay, at that point in time, the hospitals chat with each other. And in our area, it's, Trios and Lourdes and Cadlick, and we say, okay, I have almost an empty waiting room, and I can move 10 beds. So, roughly I have 10 beds available, and a couple of nurses called in this day, so we can't take a whole lot of red or immediate victims, but we can take a whole lot of green victims. So you might get a call in from one hospital that says, okay, I have enough resources for 6 greens and 3 yellows and 1 red, because I have a ventilator, just one. So it'll kind of look like that when they talk with each other. So out on the field now, the EMS is deciding what's green, what's black, which we don't want, what's red, and what's yellow. So our minor patients are going to be the walking wounded. As one way to say that is, can everybody that can walk to me come here? Okay, so now we've decided who our green ones are going to be. They're probably going to be seen, they might have some big cuts or bruises, big gash on their head, something like that, that's not bleeding too terribly bad, but they can walk to you, so they're green. And then we have our let's go into the deceased. So we're going to, if we do a head tilt chin lift on this patient and they have no respirations, then they're considered deceased, and you move on. And this is where things really kind of get a lot more different than our normal triage looks. So we're not spending all of our resources on that person. We're moving on. Our immediate ones are the ones that we're going to be spending our most time on. And this is our patients that are breathing but unconscious, if they have respirations over 30, if they have a cap refill of greater than 2 or no radial pulses. You're going to want to control that bleeding right away, and then you can move on. If they're unable to follow simple commands, then they're also in this red department. Otherwise, they're delayed. And these are the guys that are going to be respirations of under 30, a perfusion of less than 2, a capillary refill of less than 2, and they can follow some simple commands. So, our little saying, remember respirations 30, perfusion 2, mental status can do. Then they're placed in this yellow zone. Not going to spend too much time on this slide, even though it looks really super busy, but basically this is the one that was developed for children, and it's hard to say that if a child is no longer breathing, then we can't at least do something for them. So this helps everyone on the EMS side of things sleep a little bit better at night. So if the patient is not breathing, then you can reposition that airway. And if they do have a palpable pulse, then you can give 5 rescue breaths for this patient. So they can be moved from that deceased category to the immediate category with a little bit more aid. But it's something that's nobody likes to talk about, right? It's no fun at all. I won't spend too much time on that slide. All right, I'm going to stop here and we'll get started back here in a moment.